All right, good morning, everybody. Welcome to Pediatric Grand Rounds. We're so excited to have all of you here in the room, and those of you who are online, thanks for being here. Usual reminders for you, for our online friends. If you have a question or comment for our speaker, you can type it into the chat box, and I will be watching that, and I will be able to ask your question in the room. And another just random announcement, but important, we are not here next week because our team has a competing conference at that time. So if you're planning to come to Grand Rounds all year, which we love, just please skip next week. And now I get to introduce Dr. Kogan, who's going to introduce our speaker for today. Thanks so much for being here.
I have the honor of presenting Dr. Chris Russell, who will be here to give Grand Rounds. Chris and I work together, do some research. So Dr. Russell is an associate professor of pediatrics in the Division of Pediatric Hospital Medicine at Stanford University and a board-certified academic pediatric hospitalist at Lucile Packard Children's Hospital. He completed his undergraduate degree in psychology and biology at Harvard University, his medical degree also at Harvard. Then he went to his pediatric residency at the University of California, San Francisco campus, and got a master's of science in clinical biomedical and translational investigations from USC. His clinical responsibilities include caring for children hospitalized for a variety of illnesses, and his research focuses on developing evidence-based care for hospitalized children with medical complexity, including acute respiratory infections, such as pneumonia and bacterial tracheitis. Dr. Russell has received a lot of grants, too many really to describe here, but most recently, in August of 2021, he received a 5-year R01 award from the Agency for Healthcare Research and Quality to study bacterial respiratory infections in children with tracheostomy, and I've had a pleasure of serving as a site PI on Dr. Russell's study. Outside of his clinical and research responsibilities, he focuses on research mentorship of medical students, residents, and pediatric hospital medicine fellows, as well as improving underrepresented minorities in medicine throughout the continuum of physician training. Dr. Russell recently completed a term as the chair of the Academic Pediatric Association's Membership, Diversity, and Inclusion Committee, and is on the executive committee for the Pediatric Resident and Inpatient Settings Research Network. And somehow you also find time to serve as an associate editor for the Journal of Hospital Pediatrics. So it's my pleasure to invite Dr. Russell for this presentation.
Well, it's a pleasure to be here, and thank you for everyone who's joining both online and in person. I'm really excited to present my research and some clinical stuff about respiratory infections in children with medical complexity. And this is sort of a circling back moment, because I was telling John about 10 years ago I came to Seattle when I got my institutional K award to learn about all the amazing stuff that was happening here, and met a lot of amazing people that have influenced my career for this last decade. So I'll be pointing that out as well. I don't have any really financial disclosures, although I am funded by the Gerber Foundation, AHRQ, and the NIH for work that's going to be presented today, and I received some honorariums for some work that I do, and I'm not going to discuss any off-label products. So today we're going to discuss the epidemiology and outcomes of acute respiratory infections in children with medical complexity and compare that to children with tracheostomy. We'll talk a little bit about the challenges that are associated with how we diagnose and manage acute respiratory infections in this population, and then I'm going to spend a little bit of time throughout the talk talking about health disparities that are experienced by children with medical complexity. So I think, as many people know, children with medical complexity, which I'll call CMCs moving forward, use substantial health care needs. They have repeated hospitalizations, and although they represent just about 10% of hospital admissions, they're about 40% of charges and 70 to 90% of our technology use. And one of the most common reasons children with medical complexity get admitted to the hospital is acute respiratory infections. And this accounts for billions of dollars in annual US healthcare costs. So it's a really important thing to think about as we're caring for these patients. We know that children with medical complexity who are admitted with acute respiratory, who are at risk for acute respiratory infections, face substantial morbidity and mortality. So this is an article looking at children with neurological impairments. So one subset of children with medical complexity, we know that, and then children with neurological impairment are 5 to 7 times more likely to be hospitalized for a respiratory infection compared to all other children. And when they are hospitalized, they are in the hospital for longer, so they have longer lengths of stay. They are more likely to be admitted to the intensive care units. And they are also more likely to be on ventilators, although was not statistically significant in this population. So this is the resources that they're utilizing. And this is pneumonia for all reasons, and so we know that there's different kinds of pneumonia. There's community-acquired pneumonia and aspiration pneumonia. And aspiration, when we compare in children with neurological impairment aspiration pneumonia to non-aspiration pneumonia, those who are diagnosed with aspiration pneumonia have more severe outcomes. Includes longer lengths of stay, ICU costs, and readmission. I will say that as a pediatric hospitalist who cares for a lot of children with medical complexity and who are admitted for acute respiratory infections, aspiration pneumonia is a difficult diagnosis. We don't have any, there's not a test we can do. I mean, we think, so really, I think when we talk about aspiration pneumonia in this population, it's really just a marker of severity of their pneumonia or their underlying complex chronic conditions. So as we're going to be talking about pneumonia and aspiration pneumonia throughout this talk, just remembering that aspiration pneumonia, because we don't have an objective diagnosis, it can just be used by many people to say that it's a child with medical complexity who has pneumonia. And as we know, we have a lot of clinical practice guidelines in pediatrics, especially for community-acquired pneumonia and otherwise healthy kids, but we don't have any guidelines for children with medical complexity. And so we do a lot of things to these children, and we don't have, that has no evidence, and it's high variation. So Dr. Joanna Thompson and her group out of Cincinnati looked using the FIS data set, which is an administrative data set of 47 children's hospitals, was just looking at the antibiotics that these patients get. And you can look at the bottom and sort of see these are the different classifications, but really it's just the visual picture that, they're just getting different classes of antibiotics. So there's not even any standardization between our freestanding children's hospitals about what are the classes of antibiotics these children should get, and what are the best ones to help treat and help them recover. So, as I said earlier, children with acute respiratory infections, it's one of the most common causes for rehospitalization, and one of the important groups, for this is children who have frequently hospitalizations, is children with tracheostomy. And I know there's a variety of people in the room, and I don't know if everyone's a clinician, but I just want to review a tracheostomy tube is a tube that goes into the child's neck and bypasses the upper airway, but also bypasses all of the immunity that we get from our nose and our mouth. And children with tracheostomy get tracheostomy tubes for a variety of reasons, really three main categories. One is anatomic abnormalities, so they have obstructions or narrowing like subglottic stenosis. The other big category that I think about is progression of a chronic illness. So they have neuromuscular disease like Duchenne's, they have bronchopulmonary dysplasia or other chronic lung diseases. And then some children get them for acute events, like they have an anoxic injury, they've had a non-fatal drowning event, or they've had a traumatic brain injury from an accident. And as we see, as I think people know, by bypassing the upper airway and bypassing that immunity, that some of the immune responses that come from there and protections, we're letting things go directly from the ambient air into the lungs. So all the viruses, all the bacteria that are in the air are just, have a direct pathway to the lungs, at least if you have a tracheostomy tube only. And so this is probably one of the highest reasons why they're at increased risk for infections. So over 30,000 children undergo tracheotomy placement each year in the United States. And that's, just to put this in perspective, that's the same number of children that are diagnosed with cystic fibrosis approximately each year. So similar patient numbers. And in that hospitalization where tracheotomy occurs, the mortality rates are 7 to 14%, so high mortality rates. And one of the most common reasons that even the post-tracheotomy complications is a pneumonia, which I'm going to call B-TRAINs moving forward, or bacterial tracheostomy-associated infections. And that includes bacterial pneumonia and tracheitis. So you might ask, I am a pediatric hospitalist. I did not even do a hospital medicine fellowship. Back when I graduated, there were only 3 or 4 in the country. So, how did I, as a pediatric hospitalist, get interested in tracheostomy outcomes? And so really, and part of the reason why I want to make sure this talk is I want to talk about my journey so people understand that. So, I started my career after I graduated residency at UCSF. I'm from Los Angeles originally, and for family reasons, and also because It was the best job that I was offered. I moved to Children's Hospital Los Angeles, where I worked as 100% clinical. I was not even a faculty member, so I was a contract physician, which is what we were called, which meant I worked 20 weeks of days and 50 nights on a attending-only service, largely caring for children with ventilator dependence. Because in Children's Hospital Los Angeles, we have a huge home vent population, so many home vents that they could not be all on the resident service because their whole pulmonary service would at that time would have been CF and vents. And so we had an attending-only service where I cared for 10 to 15 patients on home mechanical ventilation by myself as an attending, which was a great growth experience. And as I say here, we had about 200 patients a year admitted for a suspected B train, and 90% of those patients were on the acute care floor. So that includes the ventilator patients. And as a hospitalist, I was co-managing these patients with our pulmonology colleagues, but these patients could be managed by myself, by pulmonology primary, less often in the ICUs. But the diagnostic and treatment plans changed with every hospitalization. So I would come on service and take over my colleague, and they would say, this patient's getting, we're waiting for the culture result to come back, and then we're gonna send them home on Cipro. And then a month later or 2 weeks later, because I was doing that much service, 2 weeks later I'd come on service and the person would say, Pulm says 14 days of IV Zosyn, no changing to oral antibiotics or enteral antibiotics, and they're staying the entire course for the same presentation. So that frustrated me as a physician trying to get my feet wet and figuring out my clinical style, right? I'm new, I'm trying to figure out, and at UCSF we only had 2 patients that I know with tracheostomy, because it was a very different counseling mentality. So I didn't know much about how to care for these patients. So as these diagnostic and treatment plans changed, I was trying to figure out, well, what's the evidence that's there, and what should I be doing for these patients? What's the standard practice? So I went to the literature, and there isn't much. So it's about, like I said, it's the hospitalizations for pneumonia in this population account for 4,500 annual admissions and $300 million in charges, which again equilibrates to the amount of admissions and hospitalizations and costs for CF exacerbations prior to the modulators. So it's nearly equivalent. And Pseudomonas aeruginosa growth was about 60% of the population of the cultures. And this Hello Kitty that's on here is my lab's mascot, although it's trademarked, so I don't tell people. But this is a Hello Kitty that was made by one of my patients' families so that she could have a Hello Kitty that looked like her. I asked them if I could take a picture, and they were really gracious for that. So again, it was trying to be a good steward of the literature. So what's known about this? Well, not much. There is no evidence regarding prevention, diagnosis, or treatment. There was little information on timing and risk factors. And really that led to what I will say is care variation, increased inappropriate healthcare utilization, and inconsistent care plans with each admission, which frustrated me as the attending physician, but frustrated the families more. And so I Googled change, and this is what came up. But I decided at that point, at about 2 years into my position, to make a change and take a chance and think about how I could really positively affect the care for these children. And that meant that I had to think about becoming and pivoting to a research-focused career, which I had always thought about doing, but really didn't have the resources or the bandwidth in my current job to be able to do that. So I spent a lot of time figuring out how to get some money to buy out my time so that I could do that, which we'll talk a little bit more about later. It's not easy. So through the gracious support of 2 organizations, first of all, our local CTSA and the Academic Pediatric Association, I was able to get a career development award and get some additional pilot funding to do 2 studies that looked at what happened to kids after they got a trach placed, and what were risk factors for that first readmission for a respiratory infection after you got a trach placed. So the top study is a single center study that we did at Children's Hospital Los Angeles, and then the bottom study is a retrospective multi-center cohort study. Just to compare them, Our CHLA cohort is in the middle column, and the FIS cohort, or the retrospective study, is on the right. And for the most part, I put this up so that people can just see that they're comparing and contrasting them so they know the differences in the population. So they're pretty similar ages and gender. In LA, we have a much larger group of Hispanic and Latino patients, much higher proportion of patients on public insurance. And then our indications were a little bit different just because we're a referral center. We were a referral center in LA, so we got a lot more patients who were referred to us because they needed a trach, so they were because of prematurity and other issues. And we had a much larger proportion of patients who went on home mechanical ventilation. So half of our patients who got a new trach went home on a mechanical ventilator. And so I was looking at risk factors for the first pneumonia readmission after discharge for a trach. And what did we find? Well, we found certain demographic, underlying medical conditions and other risk factors. So Hispanic Latino ethnicity was associated with an increased risk for being readmitted for a pneumonia after trach placement. Public insurance as well. Some of these confidence intervals are not significant due to sample size, but the effect sizes are the same. And then we saw discharge on home mechanical ventilation actually was associated with a decreased risk, and I'll get to why we thought that in a little bit. And then sending patients home. So going home versus going to a facility, institutionalization was associated with a higher risk of readmission for pneumonia. So we all know that being Hispanic or other race ethnicities there's no biologic reason why that would happen. So it's really going down to health disparities and what is influencing that. So we have multiple factors that are associated with readmission. Hispanic ethnicity, Black race, and the multi-center study that I didn't show, public insurance, and discharge home. And what's the reason why? Well, as we know, there's historical and continued systemic and personal racism and bias that affects these patients. The recent history of public charge changes, and probably some upcoming changes that are happening currently, make it so that our patients don't feel comfortable, who are from these certain backgrounds, don't feel comfortable coming to the hospital. They don't feel safe, even as much as we tell them. So they don't present for care, they present later for care, and so they're more at risk for having severe outcomes. There are differences in insurance, in the presence of insurance, the type of insurance that they have due to wealth differences, educational opportunities, and even the family structure. So the bill that was just passed by the House and Senate and signed into law is going to take away, it's going to take away insurance from millions of people, and without insurance, they're again going to have higher risks for being readmitted for stuff. And then we have language barriers. We have that this affects your ability to have a medical visit and the quality of your medical visit, and home nursing. If you don't have a nurse who speaks your language, it's going to be hard to communicate with them. So really these disparities in that are seen across all diseases and all patient populations are the same for this population, and maybe even magnified just because of the severity of their illness. So just to summarize, this is talking about after they get a new tracheostomy, that hospitalization for respiratory infections is common, and there's certain factors with differential readmission risks that are suggesting underlying health disparities in this population. So I'm going to move from what happens after the trach to what happens when they get readmitted for that infection. So we're going to talk about B-train readmission. So what do we do when a child's hospitalized for a suspected pneumonia or tracheitis in a kid with a tracheostomy tube? Well, we do a lot of tests, we give a lot of antibiotics, and we do a lot of consults. And it depends on your location, but these patients might be seen by pulm, ID, critical care. I can keep going. But the challenge is, as I said earlier, we don't have any clinical practice guidelines for this population. So early on in my institutional K award, I was really thinking about what's happening. You have to sort of characterize what's happening to the patients before you can think about how to change it. So I worked with mentors and at CHLA, and really looking at what is the care variations in this population, and how are those variations associated with outcomes? And can we characterize who's at higher risk for having more severe outcomes as we define by length of stay and readmission? So this is a 4,000 child multi-center retrospective cohort study of patients who were actually treated for a bacterial pneumonia or tracheitis. And this is looking at the care variations. And we see really wide variations in the care of these patients. These are diagnostic tests just in the table. And we're looking at what happens in the first 24 to 48 hours. Well, almost all of them get a chest x-ray. Almost all of them get a CBC. Most of them get a respiratory culture. And then this is data that ended in 2014. Only about 21% of them got viral testing. And at that point, we were doing, I'm going to date myself, they were doing the direct antigens in the nose where you had to it wasn't these viral PCRs that we have nowadays that are ubiquitous. So we're doing a lot of tests, but how are we utilizing those tests? How are we utilizing that information? And so what we saw is that high utilizing hospitals, so hospitals that did a lot of testing, had the exact same outcomes as hospitals who did very little testing. And as a hospitalist, that care variation is really where the hallmark of overuse and inappropriate overuse and overtesting. And so the question is why? And again, it goes back to the fact that we have no clinical practice guidelines. So unfortunately, all children with medical complexity, if you look at all the AAP guidelines for the most part, if you look exclusion, it's always children with medical complexity. So, but they're the ones, as I showed at the very beginning, are the highest cost. So we need to really think about, at a high level, how are we integrating the evidence that we have or generating evidence for children with medical complexity so that we can include them in the guidelines and improve their care. So I've talked a little bit about, I've talked a little bit about the initial post-tracheotomy period, so what happens after they get a trach and why would they get readmitted for a pneumonia. And then I talked a little bit about what we do once they have a pneumonia in the hospital. So I think after I did this work, it was really thinking about what are the questions that need to be answered and how am I going to answer those questions. And I think, at least for people who are sort of on the physician scientist or other academic tracks, the thing we do is we write grants to get money so that we can do this. So I'm going to detour give me patience for a minute or two because I want to talk a little bit about how I did that because I think it's important for especially our trainees to see. So, John, when he introduced me, was gracious and said that I had received a lot of grants, and I have, and I'm really proud of them. So I received a 2-year institutional K award that funded 75% of my time. I got a Young Investigator Award from the APA, which is one of the most prestigious awards from them. I got our CTSI vouchers to help do some work, and then I got loan repayment. So my loans were paid off by the NIH. And I'm really proud of all of this, but I think what we don't ever show is what we didn't get. And so I'm going to start by just listing all the unsuccessful grants. I took this idea from intensivist pediatric intensivist at Hopkins, who really just talked about all the things that she missed. So I submitted a K-23, for those of you, which is the NIH Career Development Award, 5 years, 75% protected time, 3 times, not discussed. So not even in the top half. So it was just like, they were like, you're not even in the top half, we're not even spend time with you. And those are big grants. Those are big grants to put together. The money's not so big, but the time. Sorry. I mean, they're amazing. Everyone should do them. I'm just saying, it's a lot of work. It's a lot of work. Sorry. People are looking at me and they're like, no, not talking. And then, when it was, I don't know what's happening now, but Robert Wood Johnson had a Harold Amos Career Development Award, which was for underrepresented in medicine junior faculty, equivalent to a K award. submitted 4 times. And I like their process because they have an interview process. So they spring people to meet them in person. And I got an interview once and was not funded. That was a 3rd out of 4 times. So even after I got the interview, then they were like, why are you bothering? Just don't even bother. And then I tried to submit multiple foundation grants. Like, it was like our pilot grants, the American Lung Association, American Thoracic Association. I mean, that's a bunch. And these were all unsuccessful. So I was sitting in 2017, 2018, no money, what am I gonna do? And then I was simultaneously trying to get the papers out so that we could show that I had data so that I could get some other grants. So I submitted my first paper to Journal of Hospital Medicine. And they said, no, thank you. Then I submitted to JAMA Peds because I redid the analysis. Nope. Then the Journal of Pediatrics, they were like, no, thank you. Pediatric Palm, surely they care about kids with trachs and pneumonia. Nope. And then I'm the editor for Hospital Pediatrics. I was not an editor at this time, but so this is before. But I think my subspecialty journal of my subspecialty thought this was interesting. And so the other thing I just want to point out is, so resubmitting a paper 4 or 5 times is not uncommon, and it has to find its right home. And because this paper found a home, future papers found homes at not all of these journals, but some of these journals that had are judged to have higher impact. So I'm going to pivot back to now what I do. So in my current work. So again, we were thinking about how do I get some funding to be able to do this? And so I submitted a grant to the Gerber Foundation in 2019, which it's a $350,000 grant to do some foundational work to get some data that would maybe support a larger NIH federal funding. And amazingly, we were successful to get that, and we got our notice of award in January 2020. And we all know what happened then. We also know what happened in children with medical complexity and pneumonia. No, they were all home. They were all cocooned. Their families did amazing things to protect them. And I was like, what is going to happen? I got to get this preliminary data to submit this R01. I have to show them that we can recruit this number of patients. So, but thankfully, we were able to do that. This is a consortium of 6 hospitals that I was still in LA at that time. And we used that foundation award to do a 1-year prospective multi-center observational cohort study among these 6 hospitals to really look at what was happening for children who were hospitalized with a suspected respiratory infection. And this work was, the dissemination of the work was led by one of my mentees, John Morrison, who's at Johns Hopkins, who was a site PI and also received a K23 award for which I'm privileged to be a co-mentor on. And we looked at hospitalized children from 0 to 21 years who had a respiratory culture obtained within 48 hours of admission and then got antibiotics for suspected pneumonia or bacterial tracheitis. So that's how we defined evaluation for a B train. And we excluded patients who got antibiotics within the week prior just because we knew that may affect their culture results, their respiratory culture results, and the management. So Dr. Morrison was really interested in Pseudomonas and how Pseudomonas impacted our decisions to treat with antibiotics. But we know there's a lot of other factors that are listed in the middle that are associated with potential treatments or confound the relationship, including demographic factors, your acute presentation of clinical factors, your chronic medical conditions, and the tests that we do. So this was really helping us to think about how do people use individual tests to decide to give antibiotics or not. And our primary outcome was, again, a B-train treatment, so bacterial tracheostomy-associated infection treatment, which was in our study was discharge diagnosis of bacterial tracheitis or pneumonia in the discharge summary by the attending physician, as well as a full course of antibiotics, which we defined as what the team said was a full course for that, because there's no guidelines, so 5, 7, what is it, football, right? 5 is not a football.
It's not.
Yeah, okay, just making sure. I'm not a 7-day, 5, 7, 10, 14. So that was not, because this is an observational study, we weren't. So in that first year, despite what was happening with COVID. We had 549 patients who were admitted at one of the 6 hospitals for suspected bacterial tracheostomy infection, of which 451 had not seen antibiotics in the day prior. The week prior. And of those populations, 55% were treated for an infection, so over half of the cohort. And this cohort was relatively young, and with a median age of 4, a gender balance that was equal. And I think the thing that I'm really proud of about the study is that because of the diversity of the hospitals that we had a really good diversity of patient race and ethnicity, which has continued moving forward in our later work. And this to give you a sense of what these patients looked like chronically, 76% of them were at home. But only 61% of those patients had home nursing. So a lot of these families are sitting at home, caring for their child on a ventilator 24 hours a day without any support. And this is the results. Well, we actually found that clinicians aren't looking at Pseudomonas and positive cultures and using that to decide whether they're going to continue antibiotics or not. But they're using other factors like our acute clinical factors, like hypoxemia, secretion changes. We see acute chest x-ray findings, which is not surprising. Patients who had an infiltrate were more likely to be treated for pneumonia. And then we looked at sort of the lab tests, and people appropriately using the gram stain, so the more white blood cells on gram stain, the more likely you were to get treated. And then for me, what was really important was the viral testing, because now we were in COVID, 100% of patients were getting some type of viral test. 88% were getting the PCR, the multiplex PCRs, and they're expensive. And if we weren't utilizing those tests to manage patients, why were we getting them? Well, we're getting them now because everyone needed to be tested for COVID. But at least, so it was associated with a 50% decreased odds in treatment. So, this was really helpful for us because it really helped us think about now, not just we're doing all these tests, but how are people utilizing this information to make their clinical decisions. But we also really took care of, we took the opportunity to use this really rich data set to look at other things. And as I mentioned earlier, I'm interested in disparities in children with medical complexity. And Margaret Rush is a hospitalist at Children's National, and she really led our groups looking at racial ethnic disparities in the bacterial tracheostomy-associated infection lengths of stay. So on the top, we have, with the circle, is our white patients. And this is median length of stay in the hospital for people who were treated for a pneumonia. So they all were treated. Children who were white had a median length of stay of about 9.7 days, and we can see much longer lengths of stay for Black patients and Hispanic Latino patients. This is just adjusted for sites and repeated encounters. So this is really unadjusted, I would say. When we adjust it, it's the exact same results. And we're seeing large disparities in length of stay. And this is only the first year of our data. We've now looked at it through all of the R01 data that I present. I don't have it up here, but the disparities are the exact same and actually magnified not only in Black, Latino, Hispanic patients, which is now significant. We now have enough patients who have Asian and Pacific Islander ancestry background that they also have much longer lengths of stay. That's not presented here. So they're all getting treated for an infection. And I'll say the burden on the families is that our minoritized patients are in the hospital a lot longer. And the question is why? I don't have the answer to that just yet. Beyond what I talked about earlier and all of bias, but we're looking into that. So I talked a little bit about my journey, right? So I had these grants, and I got a gap, then I got this foundation award, and I was really worried about COVID because I didn't think anyone was going to get admitted to the hospital. Fortunately for my science, some of them were, not fortunate for the families, but we were able to finally parlay this into a successful HRQ R01 submission, which in August of 2021, we were awarded a 5-year award, which the 5th year is starting in August 2025, so next month, if the federal government, if there's people to process our grants. I'll stop. I was like, I'll just stop myself. I think And I took a slide out here, but I'm just going to point out, and we're talking about disparities in our patients. We can talk about disparities in R01 funding. So the year I got my R01, 200 Black faculty got their an R01, a new R01, 400 Hispanic investigators, and that was out of about 5,000 new R01s. So 2% of the R01s were going to Black PI. So I'm proud to be part of that 200. I'm also like saddened to say that that's how few were given. So the R01 study is the exact same study that we did for the foundation out. We just expanded the time points. And so I'm going to just whip through some of the data so you can see where we're at, to see the progress that we've made, because we just finished, we just closed our data set this week, or last week, so we're starting to do all the analysis. But just that cohort represented 1,800 in admissions, with a little bit older now, median age of 6 years. We continue to have a racially and ethnically diverse population, and language preferences are about 1 in 5 have a non-language English language preference. Our cohort continues to represent with 76% on public insurance only. Again, 83% are living at home, and 67% are on a ventilator. So again, we have ventilated patients, which I know you take care of at home, families with limited home nursing or intermittent home nursing, and we're asking them to be ICU nurses 24 hours a day without ICU level nursing training for the most part. And this to tell you a little bit about where we're at, about high-level outcomes. 61% of patients went to the intensive care unit, and they were there for a median length of stay of 6 years. 3/4 were on oxygen. 49% had new ventilator requirements, and that includes being 14% of overall cohort being put on a ventilator when they're not. So that's how we, just because of the way hospitals work, that's one way to identify severity. And our mortality rate, I will say, is low at 1.3%, but still not insignificant, so 1 in 100 children were dying. To go back to the viral testing, that's really the aim one of my R, to look at the viral testing, to dive a little bit deeper onto how we're utilizing it. So 88% of the patients underwent the rapid PCR testing. Now that's ubiquitous now, and 1/3 of them had a positive viral PCR test, most commonly a human rhinovirus, which people have a lot of thoughts about whether it's there forever or it's residual, but it's the most common virus. But then the third most common virus was COVID, still. And 2/3 of the patients, so 67%, were treated for an infection. So my first question was, what happens if we have a patient who has a positive viral test, but we don't treat them with a full course of antibiotics? Because the fear is that you're under-treating someone who has a potential bacterial co-infection. The virus denudes the epithelium of the airway and makes it susceptible to have invasion of the bacteria that often colonize the airway. Well, as we found, and this is in the first year of the R01, because this is early on, that ICU transfer rates, so a marker of illness severity, of escalation of care, was no different between the patients. The length of stay actually was higher in patients who were treated, which is not surprising, because when we treat for antibiotics, that's one large driver of length of stay. And our mortality rates were rare, at 1.4% overall, and no difference between the two groups, although it's really too small to be able to do any robust statistical testing. And 30-day admission rate for a bacterial tracheostomy-associated infection was 3% and higher in the patients who actually got antibiotics. So this is adjusted data, but there's a lot of confounding, so this is preliminary work, but it really suggests that in-hospital morbidity and mortality and pneumonia-related readmissions were uncommon in this population, and they actually at least weren't associated with the treatment or absence of treatment for a bacterial tracheostomy-associated infection. So I really think with some of this data, as well as thinking about the cumulative antibiotic exposure that these patients are facing, we need to rethink about giving antibiotics to every single child who has who we think might have a bacterial tracheostomy-associated infection, but who also has a positive viral test. I don't have evidence because we don't have a randomized trial, which I think that's probably one of the next steps to do. But there's a lot of feelings about that because of different experiences that people have had clinically. So next steps in our R01 data is we're going to be looking at comparative effectiveness for antibiotic duration. So all these different football ones, like 7 days equivalent to 10 days. And then we're going to look at if we grow Pseudomonas, does it always need to be treated? And I have some preliminary data that I'm not presenting today that shows that it may be safe in certain populations to be able to treat with narrower antibiotics, even if they grow Pseudomonas. So that's sort of where my career was going, and I was in LA, and I had this grant. And then I Googled like new directions, and this is what came, it's the AI image that came up, so sorry. This is not AI, but it's generated by someone. And I was really on this path of like infection, tracheitis, pneumonia, like I gotta think about clinical trials for antibiotics, and I'm gonna continue to do that. But I think when you're thinking about what research and what you wanna, your passion is, it goes back to the patients and the patient experience we have. So we have a patient who was named CL, who had progressed, he was like when I first met him, so I was at LA for 13 years, so I knew him. I met him when he was like younger. He had progressive myopathy. He got a trach and was placed on a ventilator. And his initial discharge was delayed because we didn't have a Spanish-speaking nurse. And mom was like, I'm not having somebody in my house 16 hours a day who doesn't speak Spanish. It's reasonable. And we didn't have a Spanish-speaking nurse that we could find. So he sat in the hospital, and then everyone on rounds was like, he's been here, and the utilization management people were like, he needs to go someplace, he can't sit here, he needs to go to the subacute. And I was like, this mom is trained, she knows what she's doing. And like, I would come on intermittently every few weeks on service, and I'd be like, the problem is not the parents, the problem is we don't have, and if we send them to subacute, they're not going to speak, they don't speak Spanish either, so we need to be patient-centered. So the reason why I bring this up is because I also had the pleasure of working recently with a postdoc, Lindsay Schaller, who just got her PhD. She's a nurse scientist who just got her PhD 2 months ago, and is going to be joining my lab as a postdoc. And she was really interested. She was actually she worked on, there's a craniofacial and trach vent unit. So she was a bedside nurse several years ago here, before she came down to UCSF for her PhD, and she was interested in how Child Opportunity Index, which is sort of a marker of neighborhood level conditions and structures that impact child health, how that was associated with discharge disposition in this patient population, given her experiences as a bedside nurse. So we did a study looking at children who were 5,000 children who were discharged with new mechanical ventilation, and looking at their discharge disposition, which was we defined as either home with or without nursing, or to a skilled facility. And what she found was a stepwise association between poorer COI, so worsening opportunity or more disadvantage, and higher odds of being institutionalized. So it's stepwise, and this is adjusted for many things that might cause somebody to be more likely to go to a facility. And so this was done recently, but this was inspired by CL, who, and this is what's happening. So our patients are in the hospital, and if they don't have opportunity, we're sending them to a facility. We're more likely to send them to facilities. Instead of, how do we support, as a nurse, Lindsay's like, how do we support the families so we can send them home? How do we do that? We're perfect on time. So throughout his life, he got readmitted for infections and other things, and I know the mom, and she had her home. She got her home Spanish home nurse through their WhatsApp or iMessage, like Latina mom trach vent group chat, and someone's got off the vent and said, "Hey, I'm giving up my nurse because we don't in LA you don't get a nurse if you're not on a vent," and so. So she's like, I'm going to give you my nurse. Like, so this is what we're asking our families to do. Is like, I mean, they're scrappy, and I'm thankful that they have that community, but that's not what they should be doing. We should be doing that for them. But he got readmitted during COVID for a respiratory infection, which was not COVID, and his mom looked. I had never seen her. I mean, I know her, and I was like, you just don't look like yourself. What's going on? And she's like, I'm really tired. I said, in my mind, I was thinking, aren't we all? But I was like, I mean, I didn't say it. I was like, we all, like, it's COVID, right? COVID it's burnout. It's how do we deal with that? And I was like, when's the last time you slept more than 2 hours in a row? She said 2 years. So we're asking her to be an ICU nurse. Now she had a nurse, but even with the nurse, she didn't trust the nurses because they make mistakes. They don't show up. And so she would be up, like she would, even at night, because getting a night nurse is difficult. So she would be the one doing the care at night, and then during the day, she'd be waking up, making sure, did the alarm go off? Did he get his feed? Did he get his meds? And this really, that graphic, the corny graphic that I showed about the change in direction, really spurred this change to me to think about not just the infections, but it's really the quality of life in this population. And this is what spurred my move to Stanford, was really to be able to develop a second area of emphasis in my research in quality of life in children with medical complexity. We know that the quality of life in this population is lower than general populations. Inpatient hospitalization is a driver of that poor quality of life, and that's, as a hospitalist, that's what I think about. And really, its lack of home health nursing is actually associated with these higher readmission rates, delayed discharges, and increased length of stay in patients who already experience long lengths of stay. And this work falls more disproportionately on these caregivers who are living at home, and they spend 52 hours per week providing direct care for their child. So that's 52 hours a week that they're not spending developing a parental relationship with their child. It's a medical relationship. And we all know that home health access is not equitably available, and caregivers from minoritized backgrounds who live in poverty are disproportionately more likely to provide that home-based care. And many places we don't pay them for that care. So Carolyn Foster, who some of you may know, who's an academic general pediatrician now at Lurie, who was at Seattle, did her residency and then an academic fellowship after that, has really spurned and that led a lot of this work around home care models, and it does an amazing work. But what I want to point out is when we pay our families to do this work as a CNA and we train them so they have the skills, they're more likely, you're not going to lose them as nursing. So this is not just parents, this is family caregivers as well. And we don't even pay them as much as we pay the CNAs, but they're present, they are consistent and retained, and this is despite lower rates. But I think the challenge is we can't do that everywhere. And so I'll bring it back to, so when I do grand rounds at different locations, I try to look like locally what's happening, because I think it's important to know that as well. So locally, Washington State has tried to do this. So these are two bills that came out in 2023-2024 legislative session, because many people can get paid while caring for a child with disability in Washington, except your parents. So if I hire a CNA to take care of a child with medical complexity in Washington State, they can get paid. But if I'm the parent, I can't get paid. And so these bills were both sponsored, and we can see in 2023, where did they go? They were stuck. This is in the House, the State House, stuck in committee, State Senate in committee. Didn't ever get out. So then parents are starting to like coalesce and speak up. They're still left, so now they're still left, and the bill failed in the Washington local, legislator. And one said we need to be prioritized. So what happened? Well, in Washington State, it came out, similar bill. I think this is the current, so this is as of July 2025. The similar bills are still stuck in committee. I don't know the legislative timeline of Washington State, and because I know the state legislators go in and out a little bit differently than our federal ones, but I would just encourage you to think about how you all can locally support this effort, and think about how we can have families and our patients and parents and caregivers think about how we can advocate for our patients to get, again, the support that they deserve. And I'll just remind us, if you think of, is that if you go back to Carolyn's study, they were paying CNAs, this is in Colorado, they were paying CNAs the parents $15 an hour to do this, and how much our very trained and well-experienced ICU nurses who are doing amazing work, that compensation. And that's because they've been trained up and have these specific skills. But we're expecting families to do that at home. I mean, if I had a child, I don't know if I'd be able to do it. So we're thinking about quality of life, impact on families. I don't use the word burden because it's a privilege for them to take care of their child, but it impacts them. So I'm going to close. Looks like rounds are happening soon. So I'm going to close by saying, with some thoughts. Children, respiratory infections, as I hope I've demonstrated in children with medical complexity, high morbidity and high healthcare utilization. And the one takeaway is we really need randomized prospective trials, including randomized trials in children with medical complexity. We need them to inform our care and to develop clinical practice guidelines for this population that's often excluded from our current practice guidelines. We need them to narrow the racial, ethnic, and socioeconomic disparities that are currently in this population. And probably, and equally important is we need them to improve the quality of life for the children and their families. So I'll close by thanking and acknowledging a team of people who have been around me for over a decade to do this work, both my mentors in LA, my lab, which was called Tracheostomy Research at CHLA. I'm never going to get that, Trach LA again, but I tried. My Stanford lab staff, my mentors and collaborators at Lucille Packard Children's Hospital, my collaborators across the country, including Dr. Kogan and Sarah DeYoung-Hoffman. And I will also recognize people both in this room and on WebEx who have supported me as an underrepresented in medicine physician scientist throughout my career, including Tumani, so thank you. And then my funding sources, which always, I wouldn't be able to do this work without the funding. And with that, I left some time for questions.
Thank you so much. So interesting, especially your career path. Thank you for sharing all that, all the successes and failures. And I'll turn around and wait for people to raise hands. Thanks.
So I first want to say that I went to APA for the first time in 2018, and hearing you be so open about your career journey and funding was one of the most impactful things. And I don't think I've ever said this to you, so I really appreciate you saying that. But you being open about that, I was finishing a postdoc. I had no idea how I was going to transition.
Look at you.
And
Now you have a
so
kid.
thank you for sharing that, because it makes a huge difference. Second, also thank you for talking about the legislature. One of my childhood friends has a 4-year-old with a trach, and he is a stay-at-home dad while his wife works, and goes down to Olympia to champion these exact efforts. So thank you for bringing attention to that. And my question would be, the longer stay, what do you think is going on?
Yeah, I think resources at home, so people are less likely to send someone home when they don't feel it's safe, whether that's real or perceived.
That's what I was wondering.
So that's one. I think there are some. So Crystal, the fellow, Pediatric Palm Fellow, who's I showed her picture earlier, who's looking at the comparative effectiveness. We're also looking at racial and ethnic differences in duration of antibiotics, total antibiotic stays. So I think they're probably more likely to get more longer antibiotics, which is associated with a longer length of stay. I think that there's biases in people thinking that certain races and ethnicities are at higher risk for readmission, so we should treat them longer, instead of thinking about what are the risks of giving them those additional antibiotics or being in the hospital. Iatrogenic things happen all the time. So my goal with Crystal is to show that if there are disparities in different races and ethnicities in terms of antibiotic duration, but we show no difference in the comparative effectiveness of short versus long term, then we need, again, then we can say we need to be consistent with all patients, not have it subjective based upon your thoughts. And I will say we had a grant reviewed in which even the reviewer in 2025 said, have you thought about genetic or other differences that might predispose people to And I was like, yeah, well, so it's still happening, which I will say there are certain diseases, I'm sure but this is not why these patients are staying in the hospital longer.
I grew up with a sister on mechanical ventilation, and actually she was a Stanford patient.
Oh.
But growing up, she would have many times where she would get sick, and she'd go to different community hospitals, right?
Yeah.
Because it was a chronic, quick event.
Yeah.
The ambulance would take you
Of
where
course,
it's close. And every time they would do something different,
Yeah.
to your point. How does the academic centers, the pediatric specialty organizations, which are many times hundreds of miles away from these
Yeah.
patients if they do get to go home,
Yeah.
play a better role in kind of closing the gaps of the education for these pediatric or just ER providers and hospitals in the community where they're throwing drugs very quickly. My sister grew red mans by the time she was 10 for any drug she would get because she had so many thrown at her over the years. Kind of closing those gaps because, of course, if you get to the pediatric centers, it's great. But if you're being treated in the community before you get there or when these issues come up, kind of closing those gaps.
Yeah, I mean, I think the first step is we're as academic centers, we're not even nearly consistent. So we have to clean up our shop a little bit before we can and develop some evidence that we can then say. Because if I can tell the community, I worked in Bakersfield, which is our community hospital in LA for years, and I could, if I don't have evidence, how am I going to tell somebody what you're doing is not appropriate or not the evidence-based? I think that's one. I think two, we also have to think about, we can't, I'm in the community, this is a kid that I don't see regularly. I'm going to be aggressive and do a lot of things, but then when they get transferred here, we have to have the opportunity to de-escalate. So we don't often stop or de-escalate antibiotics when they get here. We just say, oh, well, the hospital gave them ceftriaxone, so we're going to keep the ceftriaxone or whatever. And then providing feedback and education. So, there are some hospitals that will, when the patient gets discharged, will, send the discharge summary to the referring physician, which is the emergency room, and if and sort of. So I think if there's something that I'm like, if it's something pretty that I would really not do, I would probably call them directly just to let them know. But I think we have to also think about. I agree with you. Most of these children are not living near our academic medical. I mean, especially with you all. I mean, I heard there's people in Alaska, and you're going up there for clinic. In a community hospital in Alaska, a kid comes in the vent. They're going to they're going to get vancomycin. They're going to get steroids, and that's reasonable. I mean, it's not. It's because they want to make sure the kid's still safe enough to get them here. And to let you all do. So, yeah.
Wonderful. Okay, unfortunately, we're out of time. There
Okay.
were some more questions. I know you're meeting with some people this afternoon, so I think those people will have a chance to talk to you some more. And for those in the room and those online, thank you so much for being here. Dr. Russell, this was a wonderful hour, and we really appreciate all
Thank
your
you.
work.